In this video, I'm going to go over primary literature from the last 1 to 2 years that may change your practice in hospital medicine. My sources are the SHM Updates in Medicine 2024 lecture, as well as the New England Journal of Medicine Journal Watch. So let's just get started with our first question, which is rapid up titration of guideline-directed medical therapy safe? And this is published in The Lancet. It's the STRONG trial. And the reason this study is important is because there's millions of people diagnosed with congestive heart failure per year and is the leading cause of hospitalization. But optimal doses of guideline-directed medical therapy are achieved in less than 25% of patients. There's strong evidence that GDMT improves quality of life, hospitalizations, and mortality. So the study characteristics, this was a multinational open label RCT focused on 87 hospitals in 14 different countries. There were 1,085 patients ranging from age 18 to 85 with congestive heart failure diagnosed within 3 days of admission. And the exclusion criteria was intolerance to beta blockers, ACEs, ARBs, and hemodynamic instability. So in terms of the treatment group, there was a rapid titration group and then the usual care group. And the rapid titration group had up titration of their GDMT over 2 weeks after discharge. So they had close follow-up at 1, 2, 3, and 6 weeks, whereas the usual care group was just discharged routinely and followed up at 90 days. So the primary outcome was all-cause death or CHF readmission at 180 days, and the secondary outcome was change in quality of life from baseline to 90 days, and adverse events were tracked to 90 days. So first of all, what are our target GDMT doses? I feel like a lot of times we say initiate people on GDMT, but sometimes we don't actually clarify what a target GDMT dose is based on the literature. And so if you look, it's actually fairly high doses. So lisinopril, target dose of 40 milligrams, losartan of 150 milligrams, metoprolol XL of 200 milligrams, Coreg 50 BID, spironolactone 50, or Entresto 97-103. These are all almost max doses of all of these. And typically what's considered optimal GDMT is achieving greater than 50% of all of these doses. So these were based on the trials which actually showed the mortality benefit of beta blockers, ACEs, SGT2 inhibitors, and aldosterone antagonists. And you can see there was the target doses here, which were all very high, but then the mean doses was about 50% of the target doses. And so that kind of shows you why optimal GDMT is considered achieving about 50% of the target dose. If you go on UpToDate, you can also see the target dose of all of these different medications. And again, notice how high they are. So going back to the trial, so day 0, looking at patients who are on optimal doses of GDMT, you can see in the standard care group and the high intensity group, very few of these patients were on optimal GDMT. But then at day 90, the patients in the rapid up titration group were significantly more likely to be on optimal GDMT. And again, we still have very, very low optimal doses in the standard care group. So what were the results? In terms of the primary outcome of all-cause mortality or CHF readmissions, this was seen 15% in the high intensity group versus 23% in the standard care group. In the secondary outcome of quality of life, it was better at 90 days for the high intensity group. The high intensity group lost more weight, had lower BNP and lower diuretic doses. There were more adverse events in the high intensity group, 41% versus 29%, including hypotension, hyperkalemia, and AKI. However, serious adverse events were similar between groups, 16% versus 17%, as well as fatal adverse events, 5% versus 6%. So the bottom line is that rapid up titration of GDMT is safe, and patients should have very close follow-up so that their cardiologist or PCP can rapidly up titrate their medications. And I would also argue, as hospitalists in the inpatient setting, we should also be aggressively up titrating GDMT. Next question is, should we be gentle or aggressive upfront with diuresis in acute congestive heart failure? So this was published in the Journal of Hospital Medicine and was using data from landmark trials such as the DOSE trial, the ROSE trial, and the ATHENA-HF trials. So the 2022 ACC-AHA guidelines recommend decongestion with diuretics, but they don't guide how much or how fast. On the one hand, diuresing too quickly may or may not damage the kidneys. On the other hand, going too slowly may increase length of stay. So the study characteristics were from the 3 heart failure trials I mentioned earlier. There were 807 patients, and they looked at the net fluid status after 48 hours. And I took this slide from the 2024 SHM Converge lecture because I really liked the way that they showed this. But overall, most patients were 2.3 liters negative in 48 hours. And then they split these patients up into separate quartiles. The quartile with the lowest amount of urine output versus the quartile with the highest amount of urine output. And you can see in quartile 1, they only peed out a net negative of 0.4 liters, versus in quartile 4, they peed out a net negative of 5.8 liters in the first 48 hours. Then they looked at the clinical outcomes of these patients. So what was their 72-hour change in creatinine, 72-hour improvement in dyspnea, and the risk of 60-day rehospitalization or death. And you can see that among all of the groups, there was no significant change in the creatinine. So really, we didn't see an increase in AKI from aggressive diuresis. In terms of the improvement in dyspnea, the more you diuresed a patient, the more significant their improvement in dyspnea was on a visual analog scale. And again, the risk of 60-day rehospitalization or death was also significantly improved the more that you diurese these patients. So the summary was that creatinine improved up until 3.5 liters net negative at 48 hours and remained stable after that. So in my opinion, you can go even more aggressive than 3.5 liters in 48 hours, because really, I think all the best benefits were really when people were peeing 5.8 liters in 2 days. So more diuresis led to improved dyspnea scores and lower risk of 60-day readmissions. We should be more aggressive with diuresis. Next question is, should SGLT2 inhibitors be started in acute CHF during the hospitalization? This was a trial done in Nature Medicine. And the reason this study is important is because empagliflozin reduces mortality and hospitalizations in HFrEF and HFpEF based on the Emperor Preserved and the Emperor Reduced trials. So should us as hospitalists be starting this medication? This was a double-blind, placebo, randomized controlled trial from 2020 to 2021 and included 530 patients with new onset CHF or decompensated CHF. And so the treatment group was patients treated with empagliflozin while they were admitted, and then the other group was the placebo group. The primary outcome was assessed at 90 days and included a composite of time to death, number of CHF exacerbations, time to first CHF exacerbation, and symptom improvement. And this study was very interesting. It calculated these outcomes as a win ratio. So we put hashtag empagliflozin wins here. And so looking at the results, empagliflozin wins versus placebo wins. The win ratio is a little confusing, but whatever is higher is actually the winner. So in terms of time to death, empagliflozin was the winner. In terms of the frequency of CHF exacerbations, empagliflozin was better than placebo. In terms of time to CHF exacerbation, this was basically similar between both groups. And in terms of symptom improvement, empagliflozin won again compared to placebo. So the bottom line is that patients who received empagliflozin lost nearly 3 kilograms more body weight compared to the placebo group, and they were 36% more likely to have clinical benefit at day 90. Post hoc analyses have also shown quality of life differences that start at day 15 and persist out to day 90. And just as an aside about empagliflozin and Jardiance, what about using SGLT2 inhibitors in CKD 3 and 4 and patients without diabetes? So this was the EMPA kidney trial. This was done in 2022, and it was an international randomized double-blind placebo-controlled trial done in patients with CKD, with or without diabetes. And basically compared to placebo, empagliflozin had much less progression of the primary outcome, which was progression of kidney disease or death from cardiovascular causes at 2 years. So 13% in the Jardiance group and 16.9% in the placebo group. And again, this was consistent in patients with or without diabetes. So even just for CKD alone, this was effective. This is a chart of the patient's GFR. And again, I always like to point out, when you start the Jardiance, it's going to have a big drop in the GFR, but this is actually beneficial for the kidney. And you see over the long run, your rate of kidney function decline is much better, mainly because the Jardiance is reducing those pressures and the high GFR that leads to that kind of hyperfiltration injury. In terms of safety outcomes between the empagliflozin and placebo groups, they saw no significant difference in ketoacidosis or lower limb amputation. Next question is, do SGLT2 inhibitors have neuroprotective effects in addition to cardio and renal protective effects? So we already know that SGLT2 inhibitors are indicated for heart failure. They're also indicated for CKD. They're indicated for diabetes. They have all these protective effects, but what about just protecting the brain? So this was an interesting study from the BMJ in 2024 and looked at the risk of dementia after initiation of SGLT2 inhibitors versus DPP4 inhibitors. And so this was an observational study involving 110,000 matched pairs of Korean adults aged 40 to 69 years. So a little bit on the younger side, because dementia typically we're going to see in older patients. And they were followed for a mean of 670 days, which is probably a little bit short when you're looking at how many patients will be diagnosed with dementia dementia in that time. And they were initiated on either an SGLT2 inhibitor or a DPP4 inhibitor, and the primary outcome that they analyzed was new onset dementia. And if you take a look at these graphs, you can see the blue is the empagliflozin group, and the orange is the DPP4 inhibitors, and you can see significantly less dementia in the SGLT2 inhibitor group. So dementia was diagnosed in 408 patients on SGLT2 inhibitors and 764 patients on DPP4 inhibitors, which is a hazard ratio of 0.65, and the association was greater in patients who were followed for longer. So randomized controlled trials will be needed to confirm these results. And also, I think they're going to need much longer timeframes and probably an older patient population to really see. Because if you see, it was 100,000 patients, we only see 400 patients or 700 patients. It's a very minuscule amount of those patients that were actually diagnosed with dementia in the end. But definitely very interesting data and an interesting signal that may lead us to new avenues to explore in the future. So now let's move on to our perioperative medicine literature. And this is something that we as hospitalists often do. Of course, we are co-managing a lot of these patients who are on surgical services these days. And so is aspirin as effective as low molecular weight heparin in prevention of VTE for total hip arthroplasty and total knee arthroplasty? And this was done in the New England Journal of Medicine, and this was the Prevent Clot trial. And this study is very interesting because this has been going back and forth for a very long time. So aspirin versus Lovenox after total hip or knee arthroplasty continues to be a hotly contested debate. So in 2018, there was this EPCAT2 trial, which showed that there were similar rates of VTE with aspirin compared to DOAC, though do note that patients did receive 5 days of DOAC in both groups. The 2022 Crystal trial showed higher rates of VTE with aspirin compared to Lovenox. So in 2012 and 2019, the CHEST and ASH guidelines said that Lovenox is better than aspirin for prophylaxis after hip fracture. However, there was this 2022 international consensus meeting on VTE, and they claimed that aspirin is the most effective agent after joint arthroplasty. And you can see that the use of aspirin for VTE prophylaxis after total knee arthroplasty is increasing. Basically, from 2012 to 2022, the use of low-dose aspirin prophylaxis increased dramatically from 8% to 55% of cases. And if you actually look, there were less bleeding complications in the aspirin group and similar rates of DVT and PE. So let's take a look at this newest trial that's going to be adding to the literature, which is the Prevent Clot trial. So it was a randomized, multi-center, pragmatic non-inferiority trial based on 12,000 adults with any extremity fracture or pelvic fracture. And they were randomized to Lovenox 30 milligrams BID versus aspirin 81 milligrams BID. So I will note that this Lovenox dose is a little bit different than what we typically do on the inpatient medicine side, which is just 40 milligrams every 24 hours. And so the primary outcome was all-cause mortality at 90 days. And you can see there was no significant difference, 0.73% to 0.78%. And then secondary outcomes, they saw no significant difference in PEs, no significant difference in bleeding, but in DVTs, there was a significant difference where there was 1.7% in the low molecular weight heparin group and 2.5% in the aspirin group. So the conclusion is that aspirin is safe and as effective as enoxaparin in preventing fatal VTE after traumatic fracture. However, the Prevent Clot trial didn't prevent clots. There were more DVTs in the aspirin group, and DVTs are not an inconsequential problem. So remember, Lovenox is still more effective than aspirin for DVT prevention after traumatic fracture. My conclusion is that I think this is probably not the end of the story. We're probably going to still have a lot of back and forth on this and more studies going on about this. And other things that were not yet considered include the cost and the convenience of aspirin, and also how to categorize low and high risk individuals who should receive low molecular weight heparin. Maybe there's going to be a risk stratification on patients who can be fine with just aspirin versus those who should receive Lovenox. And then there are some more trials in progress, the PEPPER and EPCAT3 trials, which should give us some more data on this in the future. Now, if you've been doing perioperative medicine, you know that typically we hold ACEs and ARBs on the day of surgery to prevent intraoperative hypotension. But there was this new trial called the Poise 3 trial. And this is very, kind of one of these landmark trials because the prior Poise trials were very influential in our perioperative medication management, because the first Poise trial was the one that said we shouldn't start new beta blockers before surgery, but if they're already on beta blockers, it's okay to continue. And the second Poise trial basically said we should hold aspirin 5 to 7 days before a surgery. And so why is this study important? It's common practice to hold ACEs and ARBs on the day of surgery. And preoperative exposure to ACEs and ARBs is associated with intra-op hypotension, which is then associated with increased postoperative morbidity and mortality. So this was a randomized trial of 2 perioperative blood pressure management strategies done in 110 hospitals in 22 countries. There were 7,500 patients who were 45 years and older on an antihypertensive and had a history of vascular disease or combination of vascular risk factors. And there were 2 groups, the hypertension avoidance group and the hypotension avoidance group. So a little bit weird in the way that they designed this trial. But in the hypertension avoidance group, they basically continued ACEs and ARBs throughout surgery, and they had a target map goal of greater than 60. In terms of the hypotension avoidance group, they held ACEs and ARBs before and 2 days after surgery, and they had a target map of greater than 80. So in terms of the results, the primary outcome was composite of major CV complications at 30 days, and there was no significant difference between the hypertension avoidance group and the hypotension avoidance group. In terms of secondary outcomes, again, there was no difference in myocardial injury, all-cause death, or surgery being postponed or canceled due to low blood pressure. However, there was a significant increase in intraoperative hypotension in the group who did continue their ACEs and ARBs, 24.9% to 19.1%, and this was a significant difference. So in conclusion, in patients with hypertension undergoing non-cardiac surgery, holding ACEs and ARBs had no impact on perioperative cardiovascular outcomes at 30 days. The conclusion is that continuing ACE and ARBs is reasonable if the risk of hypotension is low. So if somebody is very hypertensive all the time, probably should just continue their ACEs and ARBs. If the patient has well-controlled hypertension, however, maybe it's more reasonable to continue holding their ACEs and ARBs. So coming next is what about renal outcomes? Because this one did not find a significant difference in cardiovascular outcomes, but it did see that significant increase in intraoperative hypotension, which could mean that potentially these patients were getting AKIs at a higher rate. And so the jury's still out on that. Is this going to change your practice? Let me know down in the comments down below. There was another study with similar results. And so this was a French study that was done in 2,200 adults, and they had a simpler study design than that hypertension avoidance thing. And they basically chose to either continue their medication through the day of surgery or discontinuing it 48 hours before surgery. And the composite primary outcome of all-cause mortality and post-op complications was similar between both groups, including acute kidney injury. So again, let me know if this is going to change your practice down below. I'm interested to hear what you guys think. In 2024, we have some updated guidelines from the ACC and AHA. And this is really good because the last guidelines that were released were a decade ago in 2014. So the new guidelines in 2024 now has recommendations regarding the use of the Duke Activity Status Index in addition to METs. So especially in patients where you can't really determine their METs very well, you're not really sure, can they go up a flight or two of stairs and get that greater than 4 METs? Using the Duke Activity Status Index is a good calculator to estimate their number of METs. They say now that it is reasonable to obtain cardiac biomarkers such as BNP and troponin and trend after surgery. And now they have even less support for stress testing prior to surgery. So already we were pretty basically judicious with prescribing stress testing prior to surgery. Because if it's an urgent surgery, then the patient needs to go to surgery regardless. Otherwise, for elective surgeries, they needed to be less than 4 METs and have an elevated RCRI score or Gupta score for cardiac risk, and then you could consider stress testing. But now, as of 2024, the guidelines suggest only if they are elevated risk plus poor or unknown functional capacity, plus they have an indication for testing independent of the surgery. For example, they've been having symptomatic chest pain, or they have suspected high-risk myocardial ischemia. However, the ACC-AHA doesn't really clarify how clinicians should determine if somebody has suspected high-risk myocardial ischemia. But basically, we had kind of these 2 factors before, elevated risk and poor unknown functional capacity. Now we have this additional qualification about having a separate indication for getting stress testing. So now we're going to be even less likely to recommend stress testing. And kind of going off those last two trials that we looked at, but for most patients, they now recommend it is reasonable to continue antihypertensive medications through the perioperative period. So maybe this is going to be something you're going to find yourself doing more often, which is opting to continue the ACE or ARB on the day of surgery. What is the optimal transfusion threshold in patients with acute MI? So this was the MINT trial done in the New England Journal of Medicine. The trial was done because we typically have a transfusion threshold of less than 7 or less than 8 per the TRIC and the TRIS trials. However, patients with acute myocardial infarction may benefit from a higher hemoglobin level. So this was 3,500 patients with acute MI who were assigned to a restrictive transfusion goal of less than 7 to 8 versus a liberal transfusion of less than 10. And the primary outcome was the composite of myocardial infarction or death at 30 days. And you can see in the restrictive transfusion group, it was 16.9% versus 14.5% in the liberal transfusion group. However, this was not quite significant. It was almost a significant result, but not quite. So subgroup analyses were subsequently calculated, and this is kind of the data that they found after stratifying the patients by their hemoglobin targets. So in the patients who were transfused to less than 7, their chance of recurrent MI or death at 30 days was 18.3%, and their risk of death at 30 days was 14%. And you can see at less than 8 grams per deciliter, these all improved. And then at less than 9 grams per deciliter, this is where we saw kind of the biggest jump, 11% risk of death at 30 days versus 7.8% risk of death at 30 days. And again, these did not reach statistical significance, but a lot of people have been arguing that potentially we should be aiming for a target of less than 9 based on these results. Again, because you just see such a steep drop off in the amount of death at 30 days. And so yeah, further studies are going to have to be done to verify this result, but really it could be reasonable to consider transfusing to a target of less than 9 in your MI patients based on this data. Should we use corticosteroids in severe pneumonia? A lot of you guys may have heard of this trial already, but this is the Cod Trial, which was done in 2023 in the New England Journal of Medicine. And this study is important because community-acquired pneumonia is common and causes significant morbidity and mortality. And there's been debate about whether corticosteroids reduce community-acquired pneumonia mortality. Current guidelines advise against routine use of steroids for non-severe community-acquired pneumonia. So this was a double-blind, placebo, randomized controlled trial in 31 French centers from 2015 to March 2020. And this was 795 adults hospitalized to the ICU for severe CAP within the past 24 hours. Severe was defined by intubation with a PEEP of greater than 5, high-flow nasal cannula with P to F of less than 300 and FiO2 greater than 50%, or a non-rebreather with P to F less than 300, or a pneumonia severity index class of 5. Exclusion criteria are shown below. So the treatment group received IV hydrocortisone, and it was 200 milligrams times 4 days, and then they got a total of 8 to 14 days after that. And the placebo group just received IV saline. So in terms of the results, the primary outcome of all-cause mortality at day 28 was 6.2% in the hydrocortisone group versus 11.9% in the placebo group. And this was statistically significant. In terms of secondary outcomes, intubation was also significantly lower in the hydrocortisone group. Vasopressors also significantly lower in the steroid group. And all-cause mortality at day 90 was also significantly lower in the hydrocortisone group. In terms of safety outcomes, there was no significant difference in hospital-acquired infection and no significant difference in GI bleeding. The one significant change that they did see is an increase in the median daily insulin dose, which was 35.5 units versus 20.5 units on day 7. So in conclusion, there is a 5.6% absolute mortality reduction at 28 days, which is a number needed to treat of 18. And there was no difference in hospital-acquired infection, GI bleeding. However, more insulin was needed. So really, we should be using hydrocortisone in the severe community-acquired pneumonia patients. Next question is, how aggressively should we replace fluids in acute pancreatitis? So this is the Waterfall Trial, or aggressive or moderate fluid resuscitation in acute pancreatitis. There are 300,000 ED visits per year for pancreatitis. 30% progressed to severe pancreatitis, which has a high mortality, and there's a lack of evidence-based pharmacologic treatment. Current guidelines recommend early aggressive fluid resuscitation, like 8 to 12 liters per day. So in this group, they assigned patients to an aggressive fluid resuscitation group and a moderate fluid resuscitation group. So the aggressive group got 20 cc's per kilogram and then 3 cc's per kilogram per hour LR after that. So for example, for a 70 kilogram patient, they received a 1.4 liter bolus on admission and then were kept on a 210 cc's per hour continuous maintenance after that. Whereas the moderate treatment group basically halved all those numbers. So if the patient was thought to be hypovolemic, they received 10 cc's per kilogram, and then they received 1.5 cc's per kilogram after that. And so the primary outcome was progression to moderate or severe pancreatitis. And the secondary outcomes were organ failure, length of stay, ICU admission, or severe symptoms. And so the results were pretty striking. So the amount of volume overload was significantly higher in the aggressive fluid resuscitation group, 20.5% versus 6% in the moderate group. And so this study was actually stopped early due to safety reasons. In terms of the primary endpoint, there was no significant difference in progression to moderate or severe pancreatitis, so 22% in the aggressive group versus 17% in the moderate fluid resuscitation group, and no significant differences in organ failure, length of stay, ICU admission, or symptoms. So bottom line is that early aggressive fluids and acute pancreatitis does not improve outcomes and leads to volume overload. Now we're going to take a quick detour. I'm going to just do a little bit of a for fun study. And so this study looked at, do lay people know what a hospitalist is? So this was done in the Journal of Hospital Medicine. And the study is important because names and titles carry weight and power, and they convey information about the field of practice and expertise. Accurate representation helps build trust with patients. So this was a cross-sectional survey done at the Minnesota State Fair and included 200 adults, and anyone with a medical background was excluded. So this basically just had fill in the blank questions. Pulmonologists are doctors who specialize in blank. Then they also looked at ranking people in terms of seniority. So out of these rankings or out of these titles, which one is the highest rank? And you can see that this was a fairly educated group. 67% of these survey participants had bachelor's degrees. So in terms of the results, you can see that dermatology and cardiology, everybody knew what those were. Nobody got those ones wrong. But then looking down here, hospitalists, intensivists, and internists, what were the most common wrong answers? So hospitalists, the most common wrong answer is that hospitalists take care of hospitals. Intensivists take care of emergencies, which I guess is true. I mean, if you go to the MICU, that's an emergency. Internists take care of the insides, which is true, I think. And the 12% of people said that internists were still in training. And then you can see here, nephrologists, 4% of people said they take care of the dead. So the most common wrong answers, nephrologists care for the dead, internists care for the insides or are still in training, hospitalists care for hospitals, and attendings were categorized as the most experienced 27% of the time. Senior residents were most commonly mistaken for the most experienced 44% of the time. So very interesting study, and just kind of lets you know what the general population knows about our field of practice. All right, next study. The nurse calls you for a patient to report a blood pressure of 200/95. What do you do next? So this was a study looking at the effect of intravenous AntiHypertensives on outcomes of severe hypertension in hospitalized patients without target end organ damage. And so just really briefly looking at this study, you can see that in the patients treated with IV antihypertensives, you can see that there was a significant increase in myocardial injury. So 5.9% to 3.6% in the patients who were not treated. There was no significant difference in stroke, acute kidney injury, or death. So now when nursing is asking for IV hydralazine, you can say that, well, actually, there's evidence that treating with IV hydralazine results in increased myocardial injury. But not only that, there's another trial that was published in 2023, which was, again, looking at this same kind of topic. And so this was a retrospective cohort study done at the VA from 2015 to 2017. And they basically looked at patients who received intensive treatment, which was defined by an IV medication versus a new PO medication versus those who didn't. And so they first looked at the primary outcome of inpatient mortality, stroke, AKI, ICU transfer, and elevated BNP or troponin. And in the patients who were treated with IV medications or a new PO medication, the risk of the primary outcome was 8.7% versus 6.9% in the control group, and this was statistically significant. The risk of AKI was significantly higher, and the risk of ICU transfer was also significantly higher in the treated group. Looking at some of the secondary outcomes, all of these also were not in favor of the group that received treatment for their blood pressure. So increased hypotension, increased discharge to SNF, and decreased discharge to home when they were treated intensively for hypertension. So they then stratified this into patients who were treated intensively, and they looked at whether they received a PO medication or if they received an IV medication. And you can see that any of the patients who received IV medications had a much, much worse outcomes. So the odds ratio of them reaching the primary outcome was 1.9 in the IV medication group. Death was 1.79 odds ratio, and ICU transfer was significantly higher in the IV medication group. So if you are going to treat with something, PO at least is not as bad as IV, but really you got to avoid those IV antihypertensives. So among older adults hospitalized for non-cardiac reasons, intensive treatment of asymptomatic hypertension is associated with increased morbidity, AKI, transfers to ICU, and myocardial injury, especially with IV medications. So now you have the data to back it up on why we don't need to treat asymptomatic severe hypertension in the hospital. Here's something cool that I just wanted to bring up really quickly. In the pipeline, we're starting to get some evidence for these triple single pill combination therapies, which I think would be really great for patients. It would just make it so much easier for them, improve adherence. And so I'm thinking in the future, we probably will start seeing some more of these combination pills. The problem is right now that they're very expensive. And so that's why we don't necessarily see it right now. But they're working on this one called GMRX2, and it includes telmisartan, amlodipine, and indapamide. And they really talk about how a lot of these medications together kind of prevent each other's side effects. So, the potassium might go up with telmisartan, but then you have the thiazide that's going to lower your potassium level, which will help. And then also, if you get some swelling with the amlodipine, potentially the diuretic may help with that as well. Next question is, how effective is Turlypressin for the treatment of HRS? So this is a treatment that's already been being used in Europe for quite some time now and was recently FDA approved. And we had this confirmatory study in the New England Journal of Medicine. And so what is Turlypressin? It's a synthetic vasopressin analog with vasoconstrictor activity in the splanchnic and systemic vasculature, and it results in decreased portal blood inflow and reduced portal hypertension. So the primary endpoint in the study was verified HRS reversal, which was defined as 2 consecutive serum creatinine measurements of 1.5 or less, at least 2 hours apart. And they also looked at survival without dialysis for at least 10 days after treatment completion. And so the study basically verified that Turlypressin was effective for treatment of HRS. Now, some of the adverse events that they saw was respiratory failure, and this was thought to be due to redistribution of circulatory volume. So this is something to watch out for once you start somebody on Turlypressin. And the most common cause of death while receiving Turlypressin or placebo was respiratory failure, which happened in 3% of the Turlypressin group and 0% in the placebo group. And then I just wanted to bring up one last interesting new treatment that's actually just been FDA approved, and this is renal denervation for managing hypertension. And so this is basically for patients who have severely resistant hypertension, refractory to multiple medications. They actually take these catheters and they do radiofrequency ablation of the nerves in the renal arteries. And this has been found to be effective for treatment of this resistant hypertension. So this is something that we may start to see more of. This was actually first found in 2009 to be effective, but now only in 2023 has it finally been FDA approved. So again, here's all the literature that we reviewed over the last 1 to 2 years. Lots of updates in heart failure literature, perioperative medicine, transfusion thresholds, this landmark Cod Trial, pancreatitis fluid management, hypertension management, Turlypressin. So lots of great new studies in the last couple of years. I hope there were some interesting studies in here that may change how you practice. I think for me, a lot of these things are going to change the way I practice. So I'm going to be a lot more aggressive with GDMT and diuresis, starting SGT2 inhibitors on everybody, which we kind of already knew. Perioperative medicine, potentially holding the ACE and ARB. Still waiting to see more data on the aspirin and Lovenox debate. And then potentially giving steroids for severe community-acquired pneumonia and giving less fluids for pancreatitis. I'm also very excited for any future studies that will be coming out in the next few years that will also be practice changing. So I hope you guys enjoyed this video. Thanks again for watching. I'll see you in the next one, and peace.